You are now listening to MedEd Talks Rheumatology, a Vindico Medical Education production. The following podcast series is titled Year in Review, Uncontrolled Gout, Comprehensive Updates on the Latest Management Strategies, a rheumatology podcast series, and is supported by an educational grant from Horizon. To earn CME credit, log into mededtalks.com and search Uncontrolled Gout, Comprehensive Updates on the Latest Management Strategies. Or click the link in the notes section of this podcast to go directly to the activity, take the test, and complete the evaluation. Before beginning this activity, please be sure to review the faculty and commercial support disclosure statements, as well as the learning objectives. Now, here's your host, Dr. Sunit Grewal.
Hello, I'm your host, Dr. Sunit Grewal. I'm a rheumatologist at the East Bay Rheumatology Medical Group in San Leandro, California, and I'm joined today by my colleagues, Dr. Khanna and Dr. Pillinger. Dr. Pooja Khanna is a professor in the Department of Medicine, Rheumatology at the University of Michigan in Ann Arbor, and Dr. Michael Pillinger is a professor of medicine and biochemistry and molecular pharmacology at the New York University Grossman School of Medicine in New York. Today, we're going to discuss some of the recent presentations from ACR Convergence, EULAR Congress, and ASN Kidney Week. In this episode, we'll focus on detection and assessment of gout. So the first abstract I'd like to go over, we saw this recent study from McCormick and colleagues that looked at target serum urate levels, recurrent gout flare rates, and gout hospitalizations. So Drs. Pillinger and Khanna, can you talk a little bit about the utility of target urate levels and treat to target approaches?
Yeah, I can start to take this one. Just a reminder that we rheumatologists at the ACR and also the Europeans recommend a treat to target approach. The American College of Physicians actually does not. They recommend what they call a treat to avoid symptoms approach, which doesn't necessarily involve urate lowering or even, let alone urate lowering to the target we set of 6 milligrams or less per deciliter. This is a study by a really good epidemiologist. It's a complicated study, but to make it simple, basically, Dr. McCormick and her group identified patients who had gout and identified a target serum urate level and looked at flare rates over the course of the next year based on that baseline target urate level to try to see what the target urates meant. And the results were actually really dramatic. The bottom line was that patients did better if their urates were lower. And what were the thresholds? Well, if you look at that threshold of less than 6 milligrams per deciliter, when that was set as the reference, just having a baseline urate within the 6 to 7 range, within the next tier up, raised the risk of having a flare over that year by more than 5-fold. So just going above the ACR and EULAR recommended target raised the risk by 5-fold. As you went up, it went as high as 50-fold, and if for patients who had a urate greater than 10. And this persisted even after adjustment for age, sex, and race. 95% of the flares that did occur happened in patients with a serum urate greater than 6, and 98 happened with a urate greater than 5. So there's a group of people who need a urate probably less than 5. In fact, about 2% of patients probably had flares even when their urate was below 5. And so we know that, our target that we talk about of 6 probably applies to the vast majority of people. But there's a small percent of people who need even more aggressive therapy. The other thing was that when they looked at hospitalizations based on flare rate for gout attacks that were bad enough to need hospitalization, these associations were even stronger. So keeping your patient down below 6 has a very good chance of keeping them out of the hospital. And we just talked about the costs of having patients in hospital. And I think this underlines the importance of getting a urate down once there's an appropriate indication for it.
Thank you for that. So yeah, I'd like to move on to another abstract. This was a study by Andres and colleagues where they looked at sonographic MSU crystal deposits in patients with gout who fulfilled remission criteria. Most patients with gout fulfilling remission criteria still showed sonographic MSU crystal deposits, and 1/3 of patients meeting remission criteria showed sonographic inflammation. So, in your opinion, what is the relevance of this, and should it impact management?
I'd love to hear Dr. Khanna on this, but I think it raises questions about what it means to have your gout controlled. These were, in fact, patients, these remission criteria, which are I think, still preliminary, but basically these were patients who were at target and who weren't having gout flares, and yet they had crystal deposition. Well, we sort of knew that. We think perhaps over time, if you keep the urate low enough, maybe you can see the crystals go away. But I think what was actually really interesting here is the fact that the ultrasound revealed inflammation, because if they're just old crystals waiting to be resorbed, we can probably wait. But what does it mean to have ongoing inflammation, not clinically flaring inflammation, but potentially low-level synovial inflammation that could be damaging joints? I don't think we know, but I think it really gives pause. Pooja, your thoughts here?
Yeah, I mean, this was a very interesting study, honestly, because we always debate what is the best way to diagnose gout, right? Whether it's a clinical exam, whether it's a classic presentation of podagra, versus whether it's demonstration of MSU crystals in synovial fluid aspirate. That we know is the gold standard, right? When you find that MSU crystal. But how often do we find the MSU crystal is the question to ask. Because when 80% of the gout patients are seen in primary care offices, they don't have a polarizing microscope to, recognize that crystal. So oftentimes the joint is not aspirated. Why? Because the patient is in pain, and we make what we call a presumed diagnosis of gout based on the criteria that have existed since, we've got multiple sets of criteria, but the most commonly used one was the 1977 until the 2015 criteria came through. But this one tells us that, the newer imaging modalities that we use, other than the previous X-rays can pick up damage, they can pick up erosive disease, but they don't pick up early disease. So ultrasound, which is a conservative method of looking at the joint, but is observer dependent, is finding what we call crystal deposition during that intercritical period that we see between acute gout flares. And when you see crystals, should we treat versus not treat? How aggressively should we treat versus, maybe just watch until symptoms develop? That is kind of thought-provoking, in my opinion. And which one to pursue? Should we, if we find certain things on ultrasound, should we chase it up with a dual energy CT, which you will discuss shortly? And slowly and steadily in my practice, the dual energy CT has become the mainstay of diagnostics, because oftentimes I don't find things on ultrasound or X-rays, or even on clinical exam.
Yeah, no, I agree with you both. I think, all of the imaging modalities that we're starting to use in gout are possibly going to and hopefully change our sort of antiquated guidelines about when we treat. So obviously, the potential for damage and the identification with these modalities hopefully will allow us to expand those guidelines and be able to treat more patients earlier.
So I have a question for both of you that I find myself scratching my head about. We know that, there are people who have asymptomatic hyperuricemia. There are people who have gout, and in between flares, we can often see urate on the joints. But we now know that a lot of those patients with asymptomatic hyperuricemia also have urate deposition on the joints. They don't meet criteria to be called gout. You need a flare to be called gout. But what are we supposed to do with the fact that the crystals are there? Do we need to treat? Do we need to at least to do studies to see whether we need to treat? That would roll treatment back very early. But I always wonder what to do when that gets called.
Yeah, you raise a very important point, Michael, because in certain countries like Japan, asymptomatic hyperuricemia actually is treated. Whereas in the United States or in the European countries, we don't treat asymptomatic hyperuricemia. Why? Because we primarily worry about the adverse effects of these drugs. Because we don't have the data in a longitudinal manner in patients with asymptomatic hyperuricemia to recommend that, yes, you do need to treat it. And this is data which is coming from the 1980s, if you remember, Michael, from Campion, that looked at about 4,000 plus patients who were followed in time to understand whether they developed hyperuricemia, and those hyperuricemic patients went on to develop gout or not. 20% of them, if I recollect correctly, developed hyperuricemia, but only 4% went on to developing gout. Now, that definition of gout is also being debated quite a bit in the last decade or so. And the Gout, Hyperuricemia, and Crystal Arthritis Network has actually looked at the labels and the definitions. There are about 11 labels with 15 additional definitions. So there isn't any clarity even to this day. Why? Because we have historically been defining gout as a disease of the joints. It is actually not what you pointed out, a disease of the joints. It's urate deposition across the body. And when we shift that paradigm, that is the point where we will see more Framingham kind of studies like you showed from, Natalie McCormick, where we are following patients in time prospectively to understand, okay, someone who develops hyperuricemia and develops urate deposition also has cardiac manifestations. The things that will kill you are the reasons why we start acting proactively and, putting in place preventative measures so that we can identify the disease earlier on and manage it aggressively. So I think that there is a subtle shift, and these abstracts are actually showing us that paradigm shift in gout.
Great, thank you. And so along similar lines, Held and colleagues looked at the clinical impact of cardiovascular MSU deposits measured by a different modality, the DECT scan, in a retrospective study. What are your thoughts on the impact of cardiovascular MSU deposits in patients with gout?
Yeah, so this is a growing body of studies that remain, I want our audience to know, remain methodologically a little bit controversial. It's about, we rheumatologists love dual energy CT. They make incredibly beautiful pictures. They help us know what's urate and what's not. There is a little bit of a challenge identifying urate that's not largely aggregated. Nonetheless, there are 4 or 5 studies at least that are using dual energy CT to try to look at the idea that urate crystals may form in the vasculature and what would be the significance of that. Long story short, for this particular study by Held et al. Was they took gout patients, compared them to asymptomatic hyperuricemics and controls, and did dual energy CT on all of them, where in the thorax and in the limb that had had a recent gout flare, they were looking for tophi in that limb, but they also looked at the vasculature. And what they found was that there was apparent vascular deposition of MSU crystals, that this deposition was much greater in the gout patients and almost non-existent in the control patients, with the asymptomatic hyperuricemics being a little bit in between. And most importantly, if they looked at the patients for prevalence of MACE, meaning major adverse cardiac events, MI, stroke, things like that, it was the gout patients who had urate deposition on the imaging who were most at risk for having this. So some cardiologists have gotten very interested in the idea that lipids in the vessels are not just lipids, actually, but that you can get cholesterol crystals that cause vascular inflammation. I was privileged to write a chapter in a cardiologist book all about that recently. And this seems to suggest that urate may get there too, and may cause not only systemic effects, but vascular effects. I think underlying what Pooja said about remembering that gout is not just the joint, it's a systemic state. Pooja, do you have thoughts?
I think there is a renewed interest in the whole inflammatory cascade, and across all specialties who manage gout, there is this initiative where, again, we want to recognize that inflammatory cascade and disease process earlier on. And if we can find modalities that can actually do that efficiently, cost the least amount to the patient, and have a higher yield, that's where the field is going. I mean, this might be the way that we diagnose gout 10 years from today instead of sticking a needle in the joint.
Great. Well, finally, let's turn to new analyses from the MIRROR randomized control trial that looked at DECT findings showing evidence of bone erosion remodeling with pegloticase therapy. Can you both share a bit about these findings and potential implications?
I mean, the study is straightforward and is good news, I think. Fundamentally, this was a secondary study using the MIRROR randomized controlled trial. The point of this study was to look at patients who had tophaceous deposits in their joints, particularly in their feet, and using those DECT images that they had along with x-rays to ask what happens when you really effectively get rid of those tophaceous deposits. And the good news was that it appears that bone started to heal itself. The word you used was remodeling, but that sort of sounds like a neutral word. The real point was that the holes that the urate was causing, the erosions, were filling in this study. Not perfectly, not fully, but it suggests that some of what we think about as the permanent sequelae of gout may not only be prevented, but maybe even can be reversed. So I think that's really exciting.
Well, that was a wonderful walkthrough for looking at data behind using the treat to target paradigm, and also how to really look at gout through some different imaging modalities. So thank you both for this wonderful discussion, and thank you to our audience for joining us on this podcast.
Thank you for listening to MedEd Talks Rheumatology. Just a friendly reminder, CME credit can be claimed through mededtalks.com. For other episodes in this series, search for Uncontrolled Gout, comprehensive updates on the latest management strategies.